going.
Terrific. Welcome, everyone. This is the Canadian Primary Care Research Network Learning Series. The Canadian Primary Care Research Network's mission is to facilitate research and spread and scale innovations by building and growing local practice-based research and learning networks and developing a primary care information system. Today's second is the second of 3 sessions that will focus on persistent but pressing issues of access to care. We started with a previous session on workforce to support access, and today we're shifting focus to the mechanisms that connect people to needed care. We often think about primary care as the front door of healthcare, but for people without a regular source of care or people with urgent needs who can't see a regular clinician, navigating access can be confusing. So today we'll focus on the architecture, what that front door actually looks like of first contact care, including expanded access to services through 811 call lines and connected services. As Nova Scotia member of the Canadian Primary Care Research Network, I'm based in Mi'kmaq, the ancestral and unceded, as well as present and future territory of the Mi'kmaq people. Given today, we'll be focusing on how the structure of systems can shape access. This is an opportunity to think about the continued call to uphold Jordan's principle and ensure jurisdictional supports and where people reach out as a first point of contact for services don't prevent Indigenous children from accessing needed services or undue delays. So without further delay, I'm going to hand things over first to Dr. O'Neill Bhattacharya to provide some context for the session, and then to colleagues Shelley Morris and Kendall Ho to add added details from other jurisdictional and policymaker perspectives. We'll have a moment for questions of clarification after each of the 3 panelists, but we've saved plenty of time for discussion at the end. So hold those cross-cutting questions for discussion once all 3 have presented. So over to you, O'Neill.
All right, thank you, Ruth, and welcome. I'm just going to tee up the slides here and hope this works. All right. All right, is everyone seeing the slides, the opening slide? We're good. All right, so perfect. So as Ruth has described, we want to talk today about the architecture of first contact care. How do we get into care? How is this shaping up across our health system? I'm the co-principal, one of the co-chairs of the Canadian Primary Care Research Network, and I'm also director of a group called the Institute for Health System Solutions and Virtual Care, based at Women's College Hospital. And so I'm going to bring to bear both of my sort of cross-jurisdictional work through the Canadian Research Network, as well as my deeper work in Ontario, working closely with policymakers like Shelley and others. So when we think about primary care and the challenges in primary care, the one that comes up the most is access. And there's sort of 3 bits to this. So the first is attachment. You've got, even though primary care in principle is comprehensive care for a subset of people, 6.5 million Canadians are not attached to a primary care team. So they don't have access to that sort of, or a dedicated source for seeking care. Of those who have a primary care team, only 35% have same or next day access for urgent issues. So the idea of like the rapid access to problems when they arise is, even when you have a regular source of care, is not easy in Canada. And there are lots of reasons for limitations in access, but human resources is one of the major ones. And this problem is not going to get better. We have higher rates of retirement during COVID, and particularly in the workforce currently, there are 16% of doctors are above 65, and they carry a caseload of 7 million patients. So this problem is likely to get worse before it gets better. And furthermore, fewer medical students are choosing family medicine, so replacing those people will be very challenging. So, how this access at baseline is very poor and likely to get worse. When we think about access, we should also think about demand. Who is asking for services? What is the demand that we're trying to meet? So if we think of a province, let's take Ontario, because that's the one I know best. The number of people at risk of any health issue in the province is about 14 million. The number of people with a symptom of a question that relates to healthcare, we don't know the answer, but it's on the order of millions of people. And of those people, 80,000 some get to see a family doctor every day. And a subset of those people go to the emergency room. At 12,000 of them, 2,000 of them get a new diagnosis of a chronic disease, and around 900 are hospitalized. Changing the number of family physicians is difficult. Changing the number of ED visits is difficult. Creating more capacity within hospitals is very difficult. But addressing the demand of those millions of people with a symptom or question, I think, is a solvable problem. And that's part of what I think, what I want us to focus on today. This piece of the access issue. Now, there's a question of what is primary care. And so, any of us who have studied Barbara Starkfield and sort of the broad principles, the first feature of primary care is its first contact care, the first place you go when you have a new problem. Now, we've said in the beginning that access to primary care for new problems or urgent problems is not great. And so that's, when we think of the performance of primary care, we have a system where some people have access to a lot of things, to comprehensive care that is well coordinated with continuity, but many, about a sixth of the population, do not have access to these other things. And so the first contact point becomes maybe the most important thing for people who don't have access to care that is comprehensive, that is well coordinated, and that includes continuity over time. So I think we want to provide primary care to everybody. Many jurisdictions, including Ontario, are aiming for 100% attachment. But as I've highlighted in the beginning, that's inherently a challenging thing. So what we need is a system that can offer first contact care in a way that is, as comprehensive as possible, with some kind of coordination and some kind of continuity. If not for the individuals, then maybe for continuity of information as you move through the system. So if we think of what are the range of needs, right? I talked about the 14 million people who are at risk and the millions who have some kind of issue. The largest group probably have required general information and probably could help themselves if they were able to access the right type of information. There's a set below that have a problem that requires some kind of triage to figure out, is this serious, yes or no? And then sometimes a diagnosis. This problem, what is the subset of possible diagnoses for the problem I have? Below that, you have a subset of people that need to talk to a person, and they need to ask probably an administrative question. Where do I find this? How do I access that? And then below that, you have a smaller subset of people that need access to some kind of allied health, either a registered nurse, a social worker, an occupational therapist, physical therapist, dietitian, or a paramedic. And then the tier below, a smaller subset again, would need a prescription that could be provided by a nurse practitioner or a pharmacist. Then there's another subset that need the comprehensive services of a family doctor. So that level of expertise to meet their need. And then again, a smaller subset that need an emergency room doctor or some other specialist. So if we think of this as a sort of hierarchy, an inverse hierarchy of needs, with lots of people needing the stuff at the top and not a lot of people needing things at the bottom, then the idea that access to primary care and family physicians is the most important issue starts to seem a little strange. It turns out that fixing all those tiers above is an easier problem than adding to the number of family physicians and getting to 100% attachment. So how do we address this? So different jurisdictions are doing different things, and we have Kendall Ho, he'll be talking about the system from BC in some detail, but it's just at a high level. If you think of this pyramid I've just outlined, in BC, they have a health services locator on their website. They have a symptom checker on their website. They have administrative staff that can provide some navigation. They also offer access to medical office assistants. There's a little bit of, you can see a little loop there where you can go from a health system navigator to a nurse to then to a medical office assistant, and then be referred into either a family physician or an emergency physician. So you start to see a bit of a triage mechanism. For allied health, there's access to dietitians and exercise professionals. That navigator can also give you access to a pharmacist to renew prescriptions. And then it is also possible to access family physicians or emergency physicians. So now you start to see that there's a bit of an approach to moving people through a system where they can start to access the appropriate needs. In Ontario, we have a similar setup. And Shelley, who is the lead for Health A11 Ontario, is going to describe this in much more detail. But again, you've got a sort of health service locator on a website, medical terminology library on a website. You have a symptom checker. You have a set of administrative staff who are health system navigators available through phone or chat. You have allied health, like registered nurses, who could then connect you to a nurse practitioner who could give you a prescription. And you have, they can also escalate to an emergency room physician under some circumstances. So this gives you a flavor of how people, how the architecture of first contact care at a system level in Ontario. And I'll just go and do a deeper dive in Ontario, just to show, how these bits might fit together. So you've got the 811, you've got the navigator, you've got the registered nurse, who previously could refer you to community services, specialists and so forth in the emergency room. Then, more recently in Ontario, we've added pharmacists who can provide prescriptions for minor ailments. And that's taken up some of the demand, and it could come through 811, or people could access that directly. And then you've got, in one region of Ontario, at an Ontario Health Team level, something called the Virtual Triage and Assessment Center, where patients can contact a medical receptionist. In this case, you see the arrow from 811, but it's actually, they can be accessed directly within that region. They can get a virtual appointment with a doctor, or an in-person appointment with a paramedic, either at home or at a clinical assessment center. And so that's a program that's in Renfrew County, but being looked at by other regions of Ontario. And then most recently, we have something called the Episodic Access to Virtual Care, which is a nurse practitioner-led service that allows for prescriptions and, again, tests and referring on to other services. So this, architecture of first contact is going to look in different provinces, but I sort of highlight this to say that there's a bunch of activity in different regions that start to fit together and maybe at some point start to look like a system. Now, if we wanted systems that are, rationally can provide care to large populations, we need to think of them, I think, as platforms. And so platforms have three key features. And this is, concepts that comes from the tech world. In platforms, you can think of eBay, Airbnb, Amazon, and so forth. And really what it is that they have three key features. One is connection. How easy is it to add new services? Secondly is comprehensiveness. So how well does it attract patients and providers? So how easy can we plug in new people and new services? And lastly, coordination. How well does the platform foster exchange and meet the needs of patients and providers? So people are needing that tier, getting care from the tier that suits their needs best. So how do we navigate that middle ground? Historically, primary care was designed to meet the needs of people who are in your rostered population or in your neighborhood and not really worry about anybody else. And we did have telehealth, but now we're moving towards structures that starting to look more like platforms that can look at these broader things of how we connect people to the thing they need. And the last thing, when we're thinking about platforms, is the building blocks. So there's three sort of building blocks. One is the infrastructure to make it easy for others to plug into the platform. This could include something like a federated digital identity. In Ontario, Identos is one of the vendors responsible for that. But the idea that the platform knows who you are and allows you to kind of move through the platform without logging in and starting all over every time. The magnet, so strategies and structures that draw people the platform when the need arises. So when you have a new question, cite first, and then you figure out what you need. And so single sign-ons are a feature that are enabled by digital identities that could, make this more of a magnet. And then lastly is the matchmaker. That we capture rich data from patients and we use that to connect you with the right thing. And here you might think of risk stratification as a way for matchmaking. So now I'm going to hand off to my colleague Shelley to talk about the work in Ontario, but I want you to just keep these ideas in the back of your mind to think about how these 811 systems look like platforms and they move towards some coherent structure that allows people to get the care they need when they need it. And now I'll hand off to you, Shelley.
Thanks, O'Neill.
Stop sharing, and then I'll get Manuela to pull that up. And so Shelley Morris is coming to us from Ontario Health. and the Director of Patient Access and Navigation.
Shelley, can you see the
Yeah,
slides?
I can see it. I think O'Neill's got a bad connection.
Yeah, just let me know when you need me to switch the slides.
Sure. Okay. Hi, everybody. I'll finish that off because O'Neill was introducing you. I'm the Director of Patient Access and Navigation Services here at Ontario Health. And we work in the population health and value-based health systems portfolio. So this portfolio really looking at health from a population level, but also we oversee the Ontario Health team structure in Ontario, the province, as well as primary care work. So with that, we'll go to the next slide and I'll take you into a little bit more detail about our service here in Ontario. So just some background, as O'Neill mentioned, we had the Telehealth Ontario program, which was in place for about 22 years, really just a toll-free number where patients could call and speak to a registered nurse. There were some other sort of allied health programs that were associated with the call center as well, and I'll talk to that in a little bit. But really, didn't have a digital presence, and so no options to sort of enhance the service over time. So the Ministry of Health decided to go back to procurement back in 2019. And also to change it to, so we wanted to introduce a digital front door, but also the 811 number, which is more in line with what other jurisdictions are doing for access to health services. So with that, the Ontarians will still be able to use the phone. So 811 is still there and always will be. But obviously it's not an emergency service. It's for non-urgent healthcare information, advice, and referrals, but adding some more features that patients can interact with online instead. And so after that procurement process, we issued the contract to a new consortium vendor in October of 2021 called the Better Access Alliance. Orion Health is the prime. St. Elizabeth Health / Phone Med delivers the call center and the clinical part of the service. Ada Health is a company out of the UK that offers the symptom assessment tool that's on the website. And Think Research is an Ontario company that delivers the health services directory component of our service, as well as the video conferencing. So the ministry led that procurement, and then in 2021, they assigned the contract to Ontario Health to oversee the implementation and ongoing management and enhancements of the service. But in our governance structure, the Ministry of Health is still sort of the face of the service and also the health information custodian for the service as well. So we have a joint governance structure with the Ministry of Health. Next slide. So the vision for the service is really that this becomes the digital front door to Ontario's healthcare system. Ahead of that procurement, we engaged patients and providers, and the patients overwhelmingly told us that they wanted one place to go. There's too many places to look for information. I don't know what's trustable. Too many phone numbers and websites. And so they really just wanted one place that's sort of trusted, where they can find, navigation to services that are most appropriate for what they're looking for. And of course, connecting to those publicly funded healthcare services and aligning with the evolving Ontario health teams to guide them through their healthcare journey. Next slide. So some of the service highlights, and I guess this is maybe just a comparison of what against sort of what telehealth was, is that now we have an annual roadmap process to identify opportunities for enhancements and improvements. So when the contract was structured and approved through our Treasury Board in Ontario, we were given the ability to enhance the service over time, which is different from what was going on with the previous phone-centered, phone-based service. We've got a robust clinical governance structure. We use a human-centered design approach for the enhancement. So we engage hundreds of patients and families and caregivers and providers from the sector every year to ideate on what we can do to improve the service over time. We've got a continuous quality improvement plan in alignment with the quintuple aim. And we also have a value-based vendor compensation structure. So really looking at identifying some outcome-based indicators that we can track the vendor against, where there's sort of an at-risk component to the compensation that they receive. So it's not just volume-based on the number of calls like it used to be. Now we're actually looking at health outcomes as a way to track the efficacy of the service. Next slide. So this is a lot, but what I want to focus on most is just, I've talked a bit about the multi-channel access. So patients can call via 811, they can use the website. We have mobile access right now through a responsive website, but we're looking at the opportunity to also have a native app through the app stores. And really patients can call and ask for really anything health related. So if they need information on how to get a new health card, we'll help them with that. If they're looking for clinical symptom triage and advice, we can do that. And also some of the purple boxes in the center that I want to focus in on are some of the things that were always available under the previous Telehealth Ontario service that I wasn't aware of, but also carried over to the new service. So patients can actually access a registered dietitian for nutritional counseling, smoking cessation through registered quit coaches, We have a refugee helpline for newcomers to the country to access specialty care if they have an illness or condition that requires specialty care. We make warm transfers and connections to mental health and addiction supports in the province, lactation consultants for new mothers. We coordinate part of the medical assistance in dying service in the province, as well as access to colorectal cancer screening for unattached patients so that they can get their fit kits mailed out to them and identify whether or not they're at risk for colorectal cancer. The other things in here, we also do intake patients for what we call the Healthcare Connect program in Ontario. So that's currently our attachment program for the province, and we're working on doing some optimization of that as well. And then the telehealth advisory service is another part of work that our call center does to provide after-hours coordination for primary care providers. So if one of their patients calls the service, we can actually liaise with the physician on call and then provide advice back to the patient, or sometimes the physician calls the patient directly. Next slide. Core features. So like I mentioned before, we've got the symptom assessment tool on the website, which I'm really excited about. I think that's a really nice option, as an alternative to the call center. If you call our service right now, a navigator will intake you within 60 seconds. They'll answer the call, but sometimes it does, for a less urgent condition, take a little while for a patient to get a call back. So the symptom assessment tool is a nice alternative that's very convenient. And getting great feedback from our users, actually. I don't know, BC has a similar tool on their website. So I think that's a real opportunity that we need to tap into, not only on Health 811, but as a potential tool for primary care to use as well. O'Neill, I know you and I have sort of discussed that. The medical condition library is nice for patients where they can go and look for information on conditions. The telephone still exists, as I mentioned, in French and English in Ontario, but we do have interpretation services available for about 240 other languages. A service directory as well to look for providers and services near you. And we've just recently introduced community programs feature, so users can actually input their postal code, and the service will surface content that's local. And that's informed by our Ontario health teams. They help us curate the information that surfaces on those pages. Next page. Just some of the referral pathways. So this kind of aligns, actually, when I look at O'Neill, your pyramid, I probably should have aligned it that way, but you did a better slide than I did on that part. So just in terms of where we send patients right now, I think O'Neill did a great job of sort of illustrating how we channel patients out. I think there's an opportunity to look at, what has been done in the Renfrew County area with the RVTAC program as the physician sort of part of it all. So that's still a bit of a TBD for us, but working closely with O'Neill's team on future state of what that might look like in the province as well. So I think we can move on from this one. I'll just say, whenever we're talking to a patient, it's always primary care first. So the question is always asked, do you have a primary care provider? And if the disposition level that our decision support tool suggests is see your primary care provider, we will try to get the patient to their primary care provider. But if they don't have one, obviously, or they can't get in to see their primary care provider within a timely manner, then we'll suggest other alternate care settings. So this is just a summary of our March data, just as an example to show how we break down, the disposition levels. And patients are assessed using something called the Schmidt-Thompson telephone nurse triage guidelines. And those are sort of the gold standard for telephone nurse triage in North America. They've got a pretty robust clinical advisory panel for both adult and pediatrics, and it's meant for telephone triage. So these are the disposition levels that we see. And it's interesting. I'm actually a registered nurse by background. I spent the first part of my career working in the emergency departments in Ontario. And I had thoughts about Telehealth Ontario too, that patients were just being sent to the emergency department all the time, but that's not actually the case. In March, we sent about 8.4% of patients to the ED or to call 911 or labor and delivery. But most of the patients are in that sort of urgent care bucket. So either right now you need to go and get seen, or, if you have access to your primary care provider, or within 24 hours. So the problem is that, as O'Neill mentioned, we're in a bit of a crisis with primary care right now. So people don't actually have anywhere to go. So they often do, especially after hours, end up in the ED. So looking at opportunities to funnel patients to more appropriate care settings through those virtual urgent care programs, pharmacy, and really, focusing on keeping patients out of the ED whenever possible. Next slide. Just a snapshot of what we see in a month. So this is a combined between our telephone service, our chats, the chat feature that's on the website, as well as the symptom assessment tool. I think we see about 2,000 calls a day roughly through the call center. During COVID, we were seeing 3,000 plus, but we've returned now to baseline. But what I really want to start to see here is starting to shift that activity away from the call center by getting people to use those digital tools when they're comfortable. Because there are studies, those are peer-reviewed studies on the ADA tool that show that it's quite accurate, and the patient experience feedback that we've had for that so far has been really great. So starting to offer that more as an option for patients to use, it's right in the moment, convenient, and we can actually map the disposition levels in that symptom assessment tool to actual Ontario services that are local to that patient. And eventually, I'll talk about this in a second, actually giving them the opportunity to book an appointment online with providers, as well as that next step to make further ensure that the patient's booking the next step in their journey. And I'm probably going over time, so I apologize. I'll move a little quicker here. So our roadmap highlights for Health 811 this year, we're going to be working on some 988 pop-ups. That's the new suicide hotline feature in Canada. As I mentioned before, centralizing on online appointment booking. So really, really interested in how we can start to integrate with the various online appointment booking tools that are out there being used by providers through one central portal. So we're starting off with a small use case to test that out this year. Ontario is expanding the Ontario breast screening program to 40 to 49. So we'll be doing some work with them to assist with that. We'll also, which is the big one this year, is providing secure login. So there will be that digital credential that O'Neill mentioned earlier for patients to log into Health 811. And this is when it really starts to become valuable from a patient perspective, because you're going to start to be able to access your health data in a provincial record for the first time in Ontario. So that's happening towards the end of this fiscal year. And we'll be putting other services behind that secure login over time as well, incrementally. Working on an AI chatbot this year as well, just as sort of more a large language model AI that's more of a conversational experience for users to ask questions for health services, non-clinical use cases just yet. But we've got a phased, sort of proposed approach for that, as well as we start to get towards maybe even being able to have AI starting to provide insights to patients based on their actual health data that's contained in their record. And then we're working more with the Ontario health teams for them to be able to promote content, and working on planning for a mental health and addictions and prevention and screening hub on the site as well. So you can see it's just becoming that sort of central place for patients to be able to access all of the health things in Ontario. Data analytics and elevation, we're working on acquiring the data from our vendor right now, so that we can have that in the Ontario Health Analytics Data Hub. That'll allow us to further analyze the Health 811 patient journey. So if we're telling a patient to go to the emergency department, what did they show up with in the emergency department? Were they a CTAS 5? Could they have gone elsewhere? There's a quality improvement opportunity there, right? Or did we tell them that they were self-care and they wound up in the emergency department as a CTAS 2 within 24 hours with a related condition? Then we've got an issue. So we want to take a look at that end-to-end patient journey, as well as the OHIP billing data, so that we can start to look at primary care utilization as well for patients that use the system. Looking at an equity assessment as well against the Ontario Marginalization Index data. And we're actually working with O'Neill's group now in the Ministry of Health to scope out what an evaluation of the service could look like as well for this fiscal year. And I think that is it for my slides. Apologies if I went over time.
Not at all. Thanks for that comprehensive overview. I did see a hand. Are there any questions of clarification before we move on? Okay, we'll save discussion till the end.
Thanks.
Over to you, Dr. Kendall.
Great, thank you very much. I really appreciate O'Neill and Shelley. Great setup in terms of thinking about the system, not only the system of principles of thinking about how systems fit with patient care, and also Shelley, an excellent demonstration of 811, the comprehensiveness of it. I'm going to approach it a little bit differently, and I wonder, I have my slide set, so I'm happy to share my slide set if that's. Just want to confirm that you can see, Ruth, I can see you. If you can give me a thumbs up if you see my slide.
I can see your slide deck. It's not yet on presenting yet.
And then
good to go.
Yes, great. Are you seeing the slide set as the slide or the preview slide?
The slide as it should be for us, not the
Perfect.
presenter.
Fantastic. So folks, I'm Kendall Ho. I'm an emergency physician in British Columbia. Also, I'm a professor at UBC Faculty of Medicine and a medical director in BC Ministry of Health at 811 Virtual Physician Service. I'm very fortunate to be on the traditional and ceded land of the Musqueam, Squamish, and Tsleil-Waututh nations, otherwise known as Vancouver. I'm a settler here and very fortunate to be able to deliver health services and also live and play in this territory. What I liked with O'Neill and Shelley giving a very good comprehensive look on the system, I'm going to do a little bit of different tact in approaching it from a patient's perspective. And also, as Shelley's pointed out in 811 Ontario, that there's interprofessional collaboration. And so I'm going to look at the BC 811 from a virtual primary care, interdisciplinary care team perspective. And give a bit of perspective of how this 811 service it's helpful, hopefully, for our patients and our family physicians and our health access services. Just want to do disclosure. The work here is being funded by the BC Ministry of Health, and that funding is transferred to UBC so that my unit, Digital Emergency Medicine, can then provide the type of organization and also evaluation. We also obtained national and provincial grants to do some of these work that we have. I sit on 5 unpaid board as listed there. And then finally, for this presentation, there's no payment for my presentation. And I'd like to highlight the funding here. And also, if you have any questions about conflicts, please raise it at the Q&A session perspective. I guess the type of patients, the type of situations, I should say, that's what Shelley and my 811 in BC is trying to address is this, that it's randomly happened that life's health emergencies happen. A new parent with a 3-month-old child, first time onset of fever, vomited twice, always happens on Friday night. A person who had a family history of cardiac disease, woke up at 3 a.m. for the first time with chest pain. Lasts about half an hour, goes away. Those are situations where a patient would naturally ask, a person would naturally ask, is this an emergency? Do I need to go to emergency departments? Can I wait till the morning to contact my family doctor for the 80% in British Columbia that attached? And for the 20%, then they ask, should I go through walk-in clinics? And so what the 811 system is trying to address is to help these individuals to say, are there ways that we can support them just in time, just for them, just in case? In British Columbia, the 811 system started in 2001. Again, fantastic nursing service, and also have pharmacists, have exercise physiologists, has nutritionists and palliative care, and also an information database for patients to search, very much similar to what Shelley's been talking about in terms of comprehensiveness of providing that self-management and also health professional support. The nursing line is meant for these urgent cases when the patient calls in and said, the nurse can respond. Usually they handle a good volume of call, but when COVID happened in March 2020, suddenly the call volume went up 7 times, and the telephone line was maximized so that nobody can call in addition to that number. In addition, there was a new scope of a disease, and also many clinics and family doctors were closed. And so it funneled all the activities into either emergency departments or into this 811 line. That's when a group of us physicians were invited to join with the nurses to provide this interprofessional care. And this is the part I'm going to focus on for the rest of my discussion. And with this, we want to achieve 4 key objectives, which is on your right hand of your slide. Number 1, to address the patient's urgent needs and reduce anxiety. It always comes with anxiety. And so having the ability for a nurse and a physician to address that together to support our patient will be very important. And secondly, we want to make sure that we preserve our acute care capacity so that for those who don't need emergency care, for those who don't need urgent care in the next 24 hours, that we are able to support them safely. And then the third is, it's not just about helping the patient say, yes, go to merge, no, not no, go to merge, but actually to support the patients to understand the journey forward and navigate the health system. And sometimes for, the new parents who have minimal contact with the health system, it could be as confusing as today, I suddenly go to a city I've never been to and try to navigate that city. And so we are in some ways as a health professional tour guide, if you will, of the health system. And then finally, it's very important that we want to make sure that this episodic care get reattached back into the longitudinal care of the patient's family doctors or nurse practitioners or the primary clinic. And for those who are unattached, we have service to reattach them to family doctors. Normally, let me emphasize that the nursing would take the calls, about 100% of the calls, only about 15 to 20% of the calls get referred to physicians. And so again, as Shelley had pointed out, a lot of patients have already been addressed by the nursing. Only when the nursing scope of practice feels that the patient need urgent physician response, either going to emerge or see a family doctor now, that these patients get referred to us. So about 15% of that volume. And so with that, since March 2020, we've been having this nurse-physician virtual care team. And the technology that was used was a low entry point at 811. So it's easy, people pick up the phone, and then we also call the patient back with a phone to start. And we found that 80% of the time, telephone contact is adequate in supporting the patient. But 20% of the time, video is indispensable. Hey, doctor, I have a cut on my face, and it's a bit jagged, it's close to my lip, it's now clotted, and so it's not bleeding anymore. I really don't want to go to the emergency department because I'm worried about COVID. Do I need to go? So those are the times where you can ask the patient to describe the wound, but there's nothing better than turning on a camera and just take a look. I have a mom who called in and said, my toddler fell off the bed about 5 feet half an hour ago. Now the ankle is very swollen. He's crying, not wanting to walk at all on the ankle. And so again, I was able to connect with the mom. The mom was very good. Technologically, within about 15, 20 seconds, we use Zoom, by the way. And so the medical version of Zoom. And so we connect with the patient, and within 20 seconds, we got attached. And so when the mom turned the phone to the child, we lost the child. And so in the next 30 seconds, what we're trying to do was chasing after the child because the child doesn't want to appear on camera. So he was running up the stairs, run around. And so for the next 30 seconds, we're doing that. And so at the end of that, I said, well, mom, why don't we just watch him a little bit? If over the next, 2-3 hours, there's no more, problem walking, we can leave alone. But you still feel that there's some, change in the gait. Yeah, go to emergency, get an x-ray. And so video becomes a very important component of this virtual care team for us to assess the patient. By the end of fiscal year 2023, which ends in March, that we've seen 182,000 patients to date. And you can see on the top left, the graph, top right, sorry, the green curve was the first year. The shock pink curve is the last year. You can see an 18% year-to-year increase. And the satisfaction rate of the patient is quite high. The bottom right are the, in terms of gender, or in terms of sex, the yellow are male, the blue are female. The blue, for females, most of them are calling for themselves, but a significant portion of them is calling as a caregiver. You can see that also there's a significant number of pediatric patients that call into this line. So in average, this line has a younger population than emergency department. You can see the Sankey diagram that initially when on the left side, the nurse referred the patient that they need to see a physician now or MD now, or they need to go to emergency department as nurses feel at their scope of practice, ED now. Now, for those who have crushing chest pain or stroke, the nurse will say, call 911, don't go to this line, which is entirely appropriate. And so for those patients that then refer to our physicians, then we start looking and talking with them, and then we start to stream them, which is represented on the right side of the Sankey diagram. Indeed, we validate that 21% of these patients would need to go to emergency department. So in those cases, we say, don't wait. It's 3 a.m. in the morning, but now you go to emergency because your chest pain is very significant that you need to rule out cardiac care or issues. And then if we go to the next blue, the green graph, that's when 40% of patients says, well, in your case with the fever and vomited twice, as long as the babies continue to feed well, you can stay at home. I'll give you a follow-up call the next morning so that we can then look at child again. But if these things happen, you need to go to the emergency department. There's a 9% of, yes, if the clinic's open now, you need to go see a physician. So MD now, go to a clinic. If you don't have a clinic in your community, such as a rural remote location, then you may need to go to emergency. So at the end of the day, about 30% of patients, we do need acute physician care. And then finally, the top one is, you can schedule a meeting with your family doctors. So that occupies the rest of the 30%. And so with this service, we were able to not only do evaluation on this, but also continue to follow the data, and the percentages stay roughly the same consistently over time. With that, the government, the Ministry of Health is very interested in leveraging this line to increase the services. So in January 2021, when Paxlovid became available for the first time, that this line was used to support the prescribing or to the screening of patients who are high risk with COVID that may get hospitalized or increased mortality. And then we prescribed Paxlovid at that particular time. And also in February of 2023, we start to realize that there are more and more of an issue of patients who don't have family doctors, but need their medication renewal. Very often they walk in an urgent clinic, or in rural remote communities, they need to walk in the emergency department and try to get a prescription renewal. They know they don't need to be there. They know that they're not welcome. And very often the emergency would say, well, why are you here for a prescription renewal? Because at that point, they were still fine. But we know that within 1 week of medications, 2 weeks, they'll get worse. And so we open up our line to support pharmacists working with us together to renew those patients without a family doctor. And so we started with that line. Finally, in September of last year, we're starting to partner with our family doctors in the province so that we can provide after-hours care. For the majority of family doctors, they don't necessarily have an after-hours strategy to support the patients at this time. Some of them make arrangements locally, but what we want to do is provincialize this, to systematize it. But that gives the patient an access to after-hours care and gives us the advantage so that in the next morning, we can refer the patients back to their family doctors if it's urgent. This gives the family doctor advantage because when the patients call in the family doctor's office, it's hard. Sometimes it's undifferentiated. The patient may think that they need urgency to see the family doctors. But now with this line, we can stratify the patient so it's differentiated patients that need urgent care, and the family doctors will see these patients more rapidly. So in some ways, this line becomes a little bit of a Swiss knife, if you will, in terms of trying to address some of the care gaps that we have. We've put together a bit of over the last 4 years, a bit of a dashboard for ourselves so that we can see from what region patients call in and what communities, what's the frequency and the timing of the day and nights that we have. And also behind this, we have some sentiment analysis to look at anxiety. Are we actually addressing those anxiety? And this dashboard helps us to create a learning health system so that we can then start to calibrate our services. And in fact, calibrate we need because we have published our study, our service in 2021 with this article. If you go for the QR code, you can get access to that article right away. And then we start looking at the concordance, as Shelley was talking about. Just because we said, please go to emergency, would the patient actually go in the end? And we found that over a 24-hour period afterwards, that 75% of the patient would actually go to emergency. When we said to the patient, please go see a family doctor within 1 week, we found that there's a 45% concordance that the patient would go see a family doctor. It could be my advice was not sound enough. It could also be the patient said, usually when I call my family doctor, it takes about 2 or 3 weeks before I get access. And then finally, for those that we said, please stay at home, very fortunately, we found that we have during the study period in this study, that we had 8 patients who died. And out of those, we have 5 of them that were referred to emergency department. 3 of them were palliative care that was not expected to need to go to emergency. But we need to continue to look at this to ensure that we have safety. And then we have additional paper to look at some of the factors, success factors, and also challenging factors that lead to concordance. What are the ways that cause patients to follow advice? What are some of the factors that cause patients to have discordance with the advice? And so I'm going to wrap up from this specificity back to the system. At the end of the day, as O'Neill said, it's about supporting patients. Primary care is absolutely the foundation. And so the family doctors, that relationship we want to uphold. This is an episodic support so that we can make sure that the patient get access. And so a group of us, including O'Neill, across Canada, published a series of papers called Essential Digital Health for the Underserved. And so how do we make sure that we have essential services for our patients? And often essential is defined by the communities and by finance. The reason I said the latter is because if we can afford everything, then everything is essential. But as a health system, as a publicly funded system, we need to choose what's essential. And so that requires a dialogue, requires us describing, in this particular context today, what is urgent primary care. And once we define what this essentiality is, then it's easier to then identify what's underserved. Because if we said this is essential, some rural remote population didn't get the full service, then it's underserved. Or those that are urban but can't get to emergency department because of different reasons, or have access to digital technology or lack of access, those are the areas we need to understand, look at. And then finally, how can digital health support to increase the robustness of serving those that are underserved? So love to have continued dialogue on this. If you're interested, again, that QR code would take you to a set of papers, 9 papers, to have that discussion. I'm going to end there. Thank you very much for your attention. And I really look forward to the opportunity for this dialogue with you. Maybe I'll hand this time back to O'Neill, perhaps.
Yeah. So Ruth is going to lead us through the Q&A. So thank you for both of those comments, Shelley and Kendall. I think it gave us a good framing of the robustness of the work that's being done in Ontario and BC, and every region is working on some version of this. So I welcome folks on the call to comment on things that are going on in their jurisdiction. We have 2 questions here. Maybe Kendall, there's one for you since you just finished. There's a question from Asif Kaku. I don't know if you can see that.
Oh, let me take a look. I'll take a look at the chat.
The question here is, did you see any concerns from the nurses regarding them providing assessment and advice without access to the patient's history, medical and psychosocial? And he's wondering about medical and legal concerns and clinical effectiveness.
Yeah, thank you for that question. So there are system pieces that are helping us to continue to increase the ability for us to get background on the patients. Number one is we have PharmaNet that we access to look at patients' previous and current set of medications that they're taking. And I think in Ontario, you also have the ability to actually start looking at that particular area. Second, that we have access to our historical notes that we have. Patients would call often. It's more than the first time that they're calling. So we're able to look at the past history. The third is that we're now linking it with a patient pathways. And so there's a funneling of the patient's electronic health record within that particular system so that we can have more comprehensive access. Finally, there's a system called Care Connect, where the care of the patient, immunizations, electronic records of previous x-rays, specialist reports, and also our reports get uploaded to Care Connect so that family doctors can access Care Connect and get all the information. So again, that gives us some comprehensiveness of the data. But we have not get access to the patient's family doctor's electronic medical record, so we don't really have that comprehensiveness of it. And so often we'll have to base on that and what patient says, both for the nurses and the physicians, to make those type of decisions at that point. And so again, hopefully, with O'Neill's discussion about having not just the service and the magnets, but the connectivity of the electronic health record, that will be very important for us. And so recently, with the interoperability legislation federally that just came down about a month ago, that will get us hopefully eventually to a good record that we can actually dive into, so that we make decisions not only based on the current episodic care, but have more comprehensiveness to make those decisions. Hopefully that answers your question.
Yeah, that's great. Thanks, Kendall. There's another question here that's probably for Shelley and Kendall, about the percentage of unattached patients calling 811 and whether it's an appropriate option to provide to the community. So Shelley, maybe you want to start on that one.
Thanks, O'Neill. Yeah, it's something actually that we're looking to collect better data on. So it's self-reported right now, and it's not collected on a mandatory basis. So it sort of depends on what the patient is calling for. But that's some of the data that we're hoping to be able to pull once we get that Health 811 data into our own analytics data hub, so that we can start comparing it against some of our enrollment databases in the province to really truly assess for how many of our patients that are using the service are attached. Just in the second part of the question too, Asif, just around the appropriateness, I think was an option to provide to the community. I'm just wondering if you could expand on that a little bit. Is it related to the Health 811 service writ large, or components of it?
Hi, Shelley. It's Asif. In primary care, there's, as you know, a big percentage of community that isn't attached or poorly attached. And right now in Ontario, the options we give people are Healthcare Connect, or actually that's pretty much it in terms of where you would send patients. So I'm just wondering whether 811, it hasn't been marketed that way, not to us anyway, not in the community, not in the primary care practices that we're in. Is this something that we should get out to the community, that this is one other option?
Absolutely. Yeah, I think we put together, and it is honestly, it's like one of the best kept secrets in Ontario right now. So we're working with the Ministry of Health because they own the communications aspects of the service, to look at how we can better promote the service moving forward. I think they're a little apprehensive right now because we're about to launch the big patient viewer access first. So we kind of want to stabilize that before we really go broad in terms of a public communications campaign to really drive utilization towards the service. But it's interesting because Ontario Health is allowed for the ministry to be able to engage providers and the sector to be able to drive awareness through those channels. So we do have a toolkit that's available for providers to use. I can drop the link in the chat for you. It's a toolkit of resources on the Ontario Health website.
That would be really excellent, Shelley. Thank you.
Thanks.
Yeah, maybe I'll reflect a little bit on the BC picture. And again, there's a lot we can learn from Shelley and the Ontario 811. That's why we are looking at how do we set up a little bit of a BC Ontario, and perhaps even across the country, about 811 network and mutually learning on those areas. In BC, we see about 17% of patients are unattached. The rest of them are attached, and they choose to call 811 for this episodic care for a variety of reasons. And so for those, we absolutely want to reattach them to their family doctors. And this 70% is average. And in fact, if you look at rural patients or regional patients, the percentage is significantly higher. They tend to have more attachment in urban areas. And the other piece perhaps might be of interest to the audience is that there's a Canadian index of depravity, and trying to identify those who, because of social determinants of health, whether they have more resources or ability to access services, which is those that are the least deprived, compared to those that are having either rural remote, have trouble accessing services. Those are the most deprived. And we found that in the rural and remote locations, especially for the 65-year-old or older, that they access 811 service a lot more. And in fact, that index of depravity is highest for the 65 and over in rural remote. And so we're trying to figure out not only about attachments, which is one very good index of where they have access to primary care physicians and nurse practitioners, but also look at the depravity index. And we want to make sure that we sway the service to support those that needs to be who are currently underserved. And then in terms of the services, we absolutely want to work with family doctors so that we can make sure that the entry of portal is here, but we want to bring them back to the family physicians that are attached. Hopefully that answers your question.
Right, there was another question for me about sort of balancing needs. And I think, we have a system where essentially through primary care, we offer everything to some people. And I think what we're trying to say is that with 811 type systems, which are not primary care, but address first contact care in a significant way and address the demand for health services, it is possible to offer something to everyone. And then a subset of people will get the comprehensive services because they're already attached. So within that, I think it's important for the primary care community to think about what do we already do well and where are the gaps? Obviously, the unattached have a wide range of needs, but things like self-management support, answering general questions, self-triage, and some of the questions that Asif asked, I don't know that we do that so well. And maybe those things are very elaborate, getting that maybe they're better offered centrally. So I think there's a question for the primary care community. So what do we do ourselves and what do we do with others? And Kendall talked about after hours care, which most family docs are not keen on providing 24/7 care and probably would look for supports. There's a question from Jen Lawson around patient ID. And to start with Ontario, and Kendall, you can chime in. Shelley, you want to talk a little bit about that?
Sure. So this work is in progress right now, and it's building out a way for patients to securely log into not just Health 811, but other services in the province. Hopefully via Health 811 is what we really want to do, because again, we want to make it the way in. It's sort of like the lobby, if you will, that opens the doors to the other places through single sign-on. So starting with our patient viewer, so that'll be where patients can go and access their health data, and also we're doing some work on digital correspondence for cancer screening that happens right now via snail mail in Ontario. So we're looking to digitize that for patients that want to opt in. I'm not sure I can release a lot of the details around the architecture of the secure login at this point. It'll be going live though fourth quarter of this fiscal year that we'll be launching the sort of first MVP for that, the minimum viable product that is, or the first iteration. Is that enough information? Sorry, I'm going to make sure that answers the question. Sorry, Kendall.
Yeah. Oh, no. I'm surmising that we may have it's similar to in British Columbia, we're launching the patient gateway. So in that, it currently is a service ID that they need to sign on and then get to the gateway. And we're putting all the patient information onto that gateway. We've started with immunization record, medication prescribing, reports, and for example, X-ray reports. And also you have seen your doctor, or you have this record of visiting. Not quite scheduling yet, not quite, hey, here's an appointment coming up, or you've been referred to this neurologist now, we're waiting for them to come back. All those kind of scheduling piece together with more comprehensive data of the patients, I think that's to come at this particular time.
All right. So thank you both, Shelley and Kendall, for your very detailed comments. I think, for those of you on the call, this is an opportunity to start thinking about systems, and primary care sits within a system. And this is a way of systematizing the connection between primary care and everything else that is within offered, and to make it much easier for, create a front door for primary patients that we haven't had historically. We're going to wrap now, but I'd like you all to complete the evaluation, it's good feedback for us as a kind of the Canadian Primary Care Research Network as we organize these learning sessions, but also feedback for Shelley, Kendall, and I as we promote these various approaches. And so look for more details, particularly in Ontario on 811. And I welcome any of you from across the country that want to learn more or contribute from your jurisdiction. We'd love to hear from you. All right, everyone, have a wonderful afternoon and take care.
Thank you.
Thank you very much.
Take care.
Bye.